Welcome to Lunchtime with the Masters, brought to you by Pica. I'm Brett Robotsky, and today we have a legend, Dr. Warren Joseph, with us today.
Come on, just because I gave you that word doesn't mean you had to use it.
Well, you were my teacher. I mean, we go back a long way, you and I.
We do, and I'm very happy to see that you've moved from just the telephone meet the masters to now we're on video. This is exciting.
Wait till you see what comes next, holograms.
Oh boy, that's it. Yeah, okay. I better lose some weight before that happens.
Warren, you trained our whole profession over the last couple decades on infectious disease and how to manage infections. MRSA's been out for probably the last decade, scaring the heck out of most of us. What's new?
Yeah, actually, it's been a little bit more than a decade, a little more than 10 years. The current MRSA, let's call it an epidemic, started in around the late 1990s, 1997, 1998, when for the first time we had MRSA coming in from the community. So instead of it being just in hospitals and nursing homes, now we were seeing patients come in from the community with it. But the treatments hadn't really changed. I mean, basically, if the patient was going to be hospitalized, you had vancomycin. Some people were using some of the oral drugs like trimethoprim sulfa, which is not a drug I particularly like, or clindamycin, which you can't count on, or my favorite oral in that case is doxycycline. It wasn't until linezolid came out around 2000 that we actually had a new drug to treat MRSA. And after linezolid, we had daptomycin come out, or Cubicin came out on the market, which was an IV. But we've actually, and that actually just went off patent. So it's been a relatively long time. Well, we've had some exciting new drug developments in the area of MRSA. One of the most exciting is a drug called iridavancin, or Bactiv. And that's actually a single dose treatment for MRSA. It's a 1,200 milligram single dose treatment for MRSA. With acute bacterial skin structure infections that has been found in the clinical trials to be equally effective to 7 to 10 days of twice-a-day vancomycin.
One dose?
Yeah, single dose.
Is it a pill? Is it IV?
No, it's IV. It has to be given through a line. It's a 3-hour infusion. But you still have the point now where you don't necessarily have to hospitalize the patients. You don't need to follow up with the patients necessarily. So that's kind of an exciting drug. There's another drug along the same lines called dalbavancin, or Dalvance, which is also single dose. It used to be 2 doses. They just got approved a new single dose formulation. We have some new orals. I mentioned linezolid a little bit earlier. There's a relatively new drug called tedizolid, which is another oxazolidinone oral antibiotic. But whereas linezolid was twice a day for 10 days, what you have with tedizolid is once a day for 6 days.
And at the end, we're talking the same thing. I mean, it doesn't make a difference whether you take 1 pill over 2 weeks or 14 pills over 2 weeks.
As long as the efficacy is the same. And with the Cevexra, or the tedizolid study, they compared themselves to 10 days of twice-a-day linezolid, and the 1 pill for 6 days was non-inferior. That's FDA speak, or equally effective. Just like with the iridavancin studies that showed the 1 IV dose of the iridavancin was as effective as 7 to 10 days of twice-a-day vancomycin IV.
So what drugs should the podiatrist be keeping top of mind to use? I mean, we should have, we see 4 or 5 different most common diseases, most common bugs. Mm-hmm. What are the drugs should we keep on top of mind?
Back in the 80s and into the early 90s, I used to do a lecture called The 6 Antibiotics That Every Podiatrist Needs to Know. And that was an earlier time. We didn't have to worry about the same sort of things. And people still, it's amazing to me. I probably haven't given that lecture in 20 years.
We still use it.
Yeah, people still come up and ask me, what were those 6 antibiotics? Well, unfortunately, the bugs have changed a little bit. We didn't have MRSA to worry about as much back then. So given that we have MRSA, we have to be concerned that MRSA may be in the infection. And if you are in a locale, which has at least a 50% MRSA rate, it's more likely than not that the organism's MRSA, you have to treat it. So my first line...
So presumptively, it's MRSA.
Yeah, I think in many cases, now, if the patient's had MRSA in the past, once MRSA, always MRSA. If the patient has a history of MRSA, like I said, if you're in an area where there's a lot of MRSA, you have to assume there's MRSA until proven otherwise. Now, if you're in a rural area, you don't have a lot of MRSA, you're not seeing it, you can still consider methicillin-susceptible staph and use cephalexin as first-line therapy. But if you're in an area that has a high prevalence of MRSA, or the patient has a history of MRSA, then I think something like doxycycline, 100 milligrams twice a day, is a good way to start empiric therapy. You can't be wrong. You have to cover the MRSA.
You said you didn't like Bactrim.
Yeah, no, I'm not a big
Is that from
fan.
the Stephen-Johnson syndrome?
Yeah, there was a paper published in Clinical Infectious Diseases, probably going back 7 or 8 years now, that looked at hospital admissions for antibiotic-associated adverse events. The number one cause was trimethoprim sulfa. I mean, not only do you have the allergies, people have sulfa allergies, but on top of that, you could have the skin reactions like a Stevens-Johnson syndrome. You could also have renal problems. There are drug-drug interactions associated with it.
Even though they're cheap, you get what you pay for.
Yeah, well, I mean, some people like them and they work for some people. Then you'd have to start asking, if you're using that, should you also add rifampin in combination? Rifampin has some drug-drug interactions you have to be concerned about. So
It's easier to just keep the other ones.
I've just never been a big Bactrim fan. That's why I like I might have said dicloxacillin. If I said it before, I meant doxycycline. I will have to double check that. Doxycycline, 100 milligrams twice a day. You just have to be a little careful because in Florida, with all your sunshine, there could be a reaction there.
Multi-resistant gram-negatives, is that stirring up the pot a lot?
Oh, absolutely. We were always concerned about MRSA and MRSA. That's all you ever hear. It's like Marsha. That's all you ever heard about is MRSA. Now, and that was the superbug. That was the flesh-eating bacteria all the press used to talk about. Now you're hearing about superbugs, and they're not talking about MRSA as much anymore. Now they're talking about these multi-drug resistant gram-negatives. And these fall into a couple of different categories. You have the ESBLs, or extended spectrum beta-lactamases, which are bugs that are resistant to penicillins and cephalosporins. But at least you can still use penams, ertapenem, imipenem, meropenem to treat those. But now we have what we call CREs, carbapenem-resistant Enterobacteriaceae, which are resistant not only to the penicillins and the beta-lactams, the cephalosporins, they're also resistant to the carbapenems.
These are bad stuff.
Right. Well, you've got, they get into your bloodstream, you're looking at mortality rates at 50%. And the drug that hospitals are going to is drugs like colistin, which is a drug from the 50s that we didn't use because it was too dangerous. So the biggest news, the latest news that hit the press a couple of weeks ago was when they found a colistin-resistant organism for the first time.
Oh, boy.
Yeah. Now, what they didn't tell you is the organism was susceptible to a lot of other antibiotics, and the patient was treated. But it was the first time they found an organism resistant to colistin. So if that now obtains the gene to make it also carbapenem resistant,
we're in trouble.
You now have a bug that we don't have an antibiotic to treat.
Well, with that, I'm almost speechless. We got to stay on top of all this. I encourage everyone to go to the forum. Go to forum.podiatricsuccess.com. Share your opinion. And thank you so much, Warren, for participating with us.
Oh, happy to be here. Thank you.